Hello and welcome. I'm Caroline West. Welcome to our program on optimising fertility. This is proudly brought to you by the Fertility Coalition, which includes VARTA, Jean Hales for Women's Health, the Robinson Institute and Andrology Australia. Now, what we've done today is we've pulled together key factors that can make a huge difference when it comes to fertility. We'll be looking at lifestyle risk factors like alcohol and smoking. We'll be looking at the impacts of age and weight. And very importantly, we'll be looking at the timing of sex as well. Now, this program has proudly been funded by the Australian Government Department of Health and Ageing under their Family Planning Grants program. And if you'd like any of the resources or any of the information that we cover today, then go to the Your Fertility website at yourfertility.org.au, a wonderful place to get a terrific set of resources. Now today we're going out across the vast rural health channel, and you'll be able to see this program live on the website or stream it, or if you'd like to go to the Your Fertility website, you'll be able to access it there. And if you'd like a DVD for free, we'll be able to organise one of those for you as well. Just go to our website for more details. Of course, today would not be possible, and it wouldn't be possible to have an interesting discussion without a panel. And I'd like to introduce to you now a wonderful panel who will be opening up this conversation on fertility. First up, I'd like to introduce you to Rob, Professor Rob McLachlan. Tell us, Rob, what's your particular interest in this area?
Certainly, Caroline. I'm an endocrinologist with interest in male reproductive medicine. For that purpose, I'm a Director of Andrology Australia, which is involved in community and professional education around the country in this area. And from a clinical practice point of view, I'm the consultant andrologist to the Monash IVF program, so I'm heavily involved in male factor infertility.
Wonderful. So we'll be hearing from you from the male perspective
Certainly.
Today.
Absolutely.
Fantastic. And next up, I'd like to introduce you to Dr. Kate Stern. Kate, could you outline for us what your particular interest in fertility is?
Thanks, Caroline. Well, I'm a gynaecologist and reproductive endocrinologist and fertility specialist, and I'm the head of a unit at the Royal Women's Hospital which specialises in endocrine and metabolic health for women in the reproductive age group. And in my capacity as a fertility specialist, I'm one of the clinicians at Melbourne IVF, and I'm in charge of clinical research for that organisation.
Fantastic. So we'll be turning to you for the nitty-gritty questions on fertility.
Yes, I hope so.
Fantastic. And I'd like to introduce you now to Professor Stephen Trumble. Stephen, welcome.
Thanks,
and
Caroline.
perhaps you could tell us a bit about your perspective in this fertility discussion.
Well, my current role is in clinical education at the University of Melbourne, the Melbourne Medical School, but primarily I'm a GP, and I've had an interest in men's health for quite a long time. And I've just recently started doing rural locums, and I'm beginning to find out more about what is involved in providing care in rural areas and also learning in rural areas.
Fantastic. Well, I hope to tap into your knowledge and wisdom there when it comes to rural health challenges. It's a very interesting angle. So perhaps we could start off, though, by asking the big question. I'll start with you, Stephen, how we actually start when it comes to this conversation with our patients, because this can be a very delicate area, can't it, to actually broach with our patients. Where should we begin? Should we be proactive?
Well, I think being proactive is a very important part of a lot of preventative health and health promotion. As a GP, I think rarely you find this as the primary reason for presentation, but it's often something that you can throw in another consultation and set the scene for a more detailed discussion.
Okay, so use it as an opportunity. There's a window of opportunity.
Exactly. Just plant the seed, so to speak, and keep on mentioning it. I mean, general practice is a longer-term relationship with a patient, with a couple, and often it takes a few mentions before they'll actually get the idea this is an important topic to consider more fully.
So you have to build that rapport and trust.
Yeah, exactly, and that's really a very important part of the first meeting you might have with a new couple or an individual who's new to the practice. It's about building that trust and setting the scene for health promotion over the next few visits.
And this is not just GPs we're talking about here, we're talking about other people within the healthcare team.
Well, anybody in the primary care team. In primary care is all about finding out about people, what's important to them, and then helping them understand what might be important they haven't actually thought of yet.
Fantastic. And Kate, from your perspective today, what's a sort of key area that you think we should be covering at some stage today?
Well, I think that as you say, there are some very important lifestyle factors involved in general reproductive health and fertility. You know, it's not just fertility, it's hormones, particularly with respect to women's health. And it's really important, I think, that people understand that they can have some control over their own destiny. It's very important for doctors and primary care physicians and all health professionals to be really aware of how important the basic lifestyle factors are, so that we can try and empower our patients and help them to maximise their fertility.
Because that's wonderfully important, isn't it? To really encourage patients and to think, yes, there's something that I can do to contribute to my fertility in a positive way.
I think that's right. We really want to maintain reproductive health rather than have to always come in at the time of pathology. It's really important to, and to make people realise that there are basic, easy, well, sometimes not so easy, but manageable things to do, that they can really aim to improve their overall reproductive health.
Mm-hmm. And Rob, you're going to be sharing with us the male perspective today. Tell us about that.
Absolutely. Well, I think it's important to recognise that male fertility is a very significant cause of human fertility problems. Perhaps a third of infertility has got something to do with the male. And so it's also common in the general population. Perhaps 1 in every 20 men have got a fertility issue. So I think it's important to engage the guys and their partner, understand this is a common problem, that things can be done to work out what's going on and get around the problem very often. So one has to be active, I think, in encouraging a discussion about the male. It's just as much as it was the female.
Because I guess that's one of the myths that we have to bust, isn't it?
Absolutely. It's very clear that there's gender equity when it comes to fertility problems.
Yeah. And so does that come as a shock to some people, do you think?
Yes, I guess some people still have the view that it's usually the woman. I think increasingly the community recognises that's not the case. And there's been much more public discussion of male fertility and other male health issues like erectile dysfunction and hormone problems. There's a lot more male health talked about, all the way through to the prostate, of course, which gets a lot of publicity. So fertility has come along with that increased recognition of the male health, reproductive health. And it certainly gives the opportunity to engage the man in lifestyle discussion, which is the point I think Kate was making. You know, they come along with a fertility concern, but at the same time you can tap into issues which affect their fertility and also their general health, because after all there's not much point having offspring if you're not going to be around to enjoy them or help them along. So it's a real opportunity, I think, to engage generally in the male health.
Which is, I think, what you were referring to before, Stephen, on that,
Yeah,
that window of opportunity to open the conversation.
That's the whole point about men's health, isn't it, Rob? It's not all below the belt.
No.
I mean, really, a lot of it's about general lifestyle. If you can engage with the man on things that are slightly less threatening about, you know, smoking activity and things like that, then you can sort of narrow in on the gonads once you've dealt with the global picture of health. I think a lot of people think that you have to have a testicular problem to think about men's health, or a prostate problem, but it's actually a global lifestyle issue for men.
The term men's health is now very, very widely applied to the social determinants of health just as much as the biomedical determinants of health. So I guess today we're talking about a fairly focused area, but you always find yourself blending out into more general health and lifestyle issues.
So it's really that holistic approach that we're talking about here, isn't it?
And that allows men to have, you sort of have to give men often permission to be able to talk about these things, because their fertility and hormonal issues are very private, and often they feel emasculated by discussing them. And I think it's sort of giving them permission for a safe environment to be able to talk about these issues.
It is very tied up with masculinity, though, isn't it, in a way?
Absolutely.
And providing somebody with a place where they can talk about this without feeling judged is hugely important.
Yeah. So perhaps what we could do is bring all of these ideas together in our first case study. Are you happy to outline a case study, Stephen?
It's a very simple case, and I mean, this is the way people turn up to primary care without a lot of records, a lot of background, and it's all about finding out what's going on and building that relationship. So the first couple that we should talk about, both 31 years old, Alana and Carl, they've just got engaged and they've moved into the area where we are, and that can be really anywhere in rural, remote Australia, and they're attending the clinic for the first time. The reason for attending is pretty common. They've come along for travel advice, 2 patients, 1 appointment, not much time. And it's actually fairly complex to prepare somebody for a trip, for their first trip to Asia particularly. And there's a bit of heart sink when they say we're just here for some quick injections.
Don't you love that? They say we're here for just, 15-minute appointment.
Well, and then the last thing in your mind is I'm going to talk about preventative health beyond the simple immunisations. But this is actually the opportunity not to get in there and do the whole thing, but just to, again, plant that seed and start people thinking about it, move them into a position of contemplating their health more broadly. They'll come with maybe a questionnaire filled out at the front desk about what their previous medical or family history is, whether they're smokers, how much they say they drink, allergies, medications and things like that. In the couple that we're talking about today, well, let's say, okay, maybe both of them smoke. The first thing that you would do as a primary healthcare nurse or doctor or whatever would be to do the basic health assessment and then focus in on the reason for being there. I think any couple is going to look a bit askance at you if you go off on your agenda about what you want to talk about when they've come in for what they see as being fairly simple, typhoid vaccination, malaria tablets if they need them, and off they go on their honeymoon. But it's about dealing with that reason for presentation, but also mentioning a few other things that are important, building that rapport, developing the trust so that when they come back and you can schedule a review appointment, you can then focus on the things that are important for a healthy lifestyle.
How do you broach the subject, though, when people are not expecting it? Because it can be one of those tricky conversations to have, can't it?
Yeah, look, better if they bring it up. But I guess part of the skill is prompting them to bring it up with just a few comments. Like, I mean, often when you're talking, it'll be about occupation or something like that. She might say, look, I'm a partner in a law firm. Or I'm aiming to be a partner in a law firm within 5 years, and you're doing the maths and thinking 31 plus 5 is 36, okay, how am I going to mention this? And so, oh, tell me about the wedding, what made you decide to get engaged and what are you planning? And, we're planning on having children, or, my parents will never accept us living together without being married, things like that. It begins to develop a picture about what's going on in these people's lives. And then you can start to put in little things about, 5 years is a long time. To be planning your career ahead. Other things turn up. Have you thought about that? They might say, we've moved to this area because there's great schools. We're planning on a family. Little cues that you can jump on. And I guess part of being the GP or the nurse is thinking about how can I grab something from that comment to put my health messages onto that's actually going to mean something to this individual person.
Yeah. Kate, do you think that young couples often have realistic expectations when it comes to their own fertility, and what time frames are the best ones to look at?
I think that's a very good question. I think there are a lot of couples who really feel at that age somewhat invincible. They've got over that sort of adolescent invincibility about, living excitingly, and they're now onto their sort of career and other interests. And I think that, people forget about the impact of age, and age is the most important factor in female fertility. I think people do forget about that. And the other misconception is that people think that fertility treatment will fix up any age issues. So it is okay to, go and wait and then try and seek help when you're older, because the fertility treatment will be able to override that. And I think that's the biggest misconception that we see. On the other hand, that stereotype of the high-flying career woman, that's actually not my experience. My experience with seeing patients, particularly women in the older reproductive age group who come on their own, is that they just haven't been able to find someone that they want to partner with. It's not so much that they're perfectionists and Mr. Not Quite Right and all of that sort of stuff. And it's not really so much that, I haven't got time for a career. It just really hasn't happened. But they still, it's more the couples that are together for a while thinking, it'll be okay later on.
And so often they put other things first, don't they? They might consider, we really want to secure our financial position, or
there's material things which are really less relevant. I think that's true.
So is it our role then to broach that area of timeframes then, realistically with patients? Yeah.
I think it is. I think it is.
I think it's also important for the partner to understand that.
That's a very good point,
Yeah, because
Ron.
you know the guy. This is a couple's decision, and sometimes I see couples where the lady's aware of the oncoming of age and the effects it could have on her fertility, and perhaps he's saying things, yes, but we have to pay the house off, or we have to do this, or we have plans for next year.
So do you see them
he needs to
separately?
listen to the fact that what you're saying to his partner is not something that can be affected. As Kate says, IVF is not going to get around the age of the female, so he needs to listen. And hear it
frequently.
And so when they go home in the car after consultation, they're having some really meaningful interaction about this issue.
You need to have the seed planted.
Yeah, it's important that that happens together, but do you see them separately as well? 'Cause sometimes there are quite different reasons going on for the two people.
Usually the couples come together and are with me together.
Yeah.
If I sense that there are issues, I'll usually examine the guy and ask his partner to step out. So I must say I don't routinely always speak to the guy separately, because the wife often wants to be involved in every single discussion and is taking notes.
Yes.
But I certainly on occasion, when if I sense there's a discordance between what page they're on, it's important to
I'm
talk to
still
them
embarrassed
individually.
by the man who called me up afterwards and said, look, I couldn't say at the time, but I actually have fathered a child with another woman
yes,
that my
yes,
wife doesn't know about,
yes,
but I reckon
yeah.
I'm okay. And that's really quite difficult in a family medicine context, but obviously he wasn't able to say that in front of her. He needed his opportunities.
When the patients come to see me, they tend to be, I think, remarkably forthcoming about their previous reproductive success. I saw a couple yesterday where she'd had 2 pregnancies with other guys and he'd had several pregnancies with other ladies, and that had all been discussed before they came into the room.
Right.
But perhaps my interaction as a specialist is a little bit different to the primary care, and particularly if they're chronic patients of the practice, and and they know all the staff and whatever, it's a bit different.
So Stephen, just sort of going back to your position as a GP in a community, what would you also like to include with this couple in terms of screening or advice just on this preconception planning?
Yeah, a lot of it's about the way that they strike you at the time about where they are in their thinking process. I mean, if they're already well on the way to thinking about having a baby and all that, you don't want to say, well, come on, get busy. I mean, that's not appropriate. It's about, trying to...
They're going on holiday.
Exactly, well, honeymoon coming up, you'd sort of hope so. But it's about... And sometimes the discussion about contraception, for example, is a good way to discuss this. I mean, okay, so you're obviously living together. Have you thought about a baby? Have you thought about contraception? Well, if not, what are you doing in terms of thinking about having a baby? It's really about planting the seed, I suppose, but also reminding them there's a whole lot of things you need to do before you get pregnant if you're going to have the healthiest pregnancy you can. So you can engage them in that sort of discussion as well about vaccination, the flu, rubella, varicella and things like that, whooping cough, all much better done before the pregnancy even starts, as well as getting diet and activity, smoking and things like that sorted out, because often they don't know they're pregnant when the fetus is at the most risk, the embryo.
And in terms of the lifestyle factors that you might chat to them about at this point?
Well, this is where I guess the GP takes a much broader view, and you might talk about the general health. And a lot of viewers will be aware of the SNAP program, where you talk about smoking, nutrition, alcohol and physical activity, more broadly about cardiovascular and respiratory health and things like that. You've always got to look for a hook, though, for people to want to engage in that sort of activity. And if they're really keen to get pregnant or starting to think about it, then it's a good way of saying, look, you want to think about having a healthy pregnancy and then a healthy life, so that you can enjoy the children as they grow up. So preventative health and motivational interviewing and counselling is all about finding something that means something to that individual person. And if they're thinking about getting pregnant, then that's when I'd really start to push the concept about pre-pregnancy planning appropriately without shoving it down their throat.
Is there anything you'd like to add to that one, Kate?
Well, I agree with Stephen. It is sort of sometimes hard to get too much detail when they're coming to see you for something else, but I always just tend to sort of barge in with a few general questions about cycles. I'd be looking for potential risk factors, warning signs that might help us to alert the patients to the fact that they might have difficulties, such as a family history of early menopause, or a family history of specific cancers, or really big problems with the cycles, very erratic cycles. So things that might impact on their subsequent fertility that it'd be great to be able to warn them about early so that they don't sort of delay their coming when they actually really do want to try and get pregnant.
So the PAP test and the contraceptive review are great chances for us to
Yeah.
talk about those sorts of things in general
That's
practice, because obviously it's a permission or ticket of entry to talk about gynecological health.
And while you're actually, it sort of gives you that sort of chat opportunity for chat while you're doing something. It's like Rob talking about examining the patient. I think what we all really try and seize are the opportunistic little chats while you're doing something else to just see if it, highlights anything. Have you had problems with your cycles? Are your periods terrible? Did your mum have any difficulties getting pregnant with you? Those sort of little things that
It's
just
very
give you
time efficient to do that while you're doing other things as well. That's really
we can
quite
all
valid.
do. Even men can do that, Steve.
You'd be surprised. We're not going to be
And you
sexist
throw in
today.
a bit of chlamydia screening. What other screening tests should providers be thinking about?
Well,
Apart from the vaccination checks and the lifestyle discussion, is there anything else that we need to be thinking about
Well, yes.
from that proactive point of view?
Again, thinking very generally, you'd probably just do a general health check. You might do some general health screening, looking for signs of anemia, urinary tract infection, things like that, as well as the vaccinations. But I don't think in the first instance you wouldn't actually sort of technicalise it too much. It's more or less a discussion, just raising the issues, getting people thinking about it. You do an examination, of course, of both, looking for varicocele in men.
when they're coming for their
and
triple
volume.
check.
And
No, sorry, I should have made that clear. You wouldn't do this. No, it's a journey. This is the joy.
This is
the joy of primary care.
This is come
It's a
back from
series
Bali
of
with
things.
Bali Belly to see
Exactly,
you
they'll
another
be back.
opportunity, another
But you've
window
got to
of
make them
opportunity.
want to come back. If you do it
Yes.
all, they'll freak out and never
Yes.
come and see you again. I walked in there and
Not that bad.
Does Doctor overdo it?
No, it's all. Today's all about planting seeds. It's about planting the seed of doing this
Yes.
later
Yeah.
on, because it's reality for the doctor or
Yeah.
the nurse as well. What can you really do in that crammed appointment? They need
Yeah.
to get their vaccinations, get their antimalarials if appropriate, and go. But they go with the plan to come back
Yeah.
and follow up on preventative health type things later on when you can give it due attention. And it's all about saying, look, I would love to deal with all these things now, but it's not in your best interest that we rush this. It's something that we need to plan for over the next couple of visits.
And Rob, we also need to make sure that we're always being very inclusive here, including the male partner as well as the
Yes,
female.
well, in this case, the gentleman's gone along with his partner, and so you're identifying, shared problems. They may both be overweight, they may both be smoking. Well, you can hardly expect her to, smarten up her act and let him continue to eat and drink whatever he'd smoke, whatever he likes. So the couple would have to begin the process of reevaluating their life with a view down the track to conception. So now's a good time to start.
And often you do things well in partnerships too, don't you? For example, if you're going to quit smoking, it's great to have a buddy.
Yeah.
Yeah.
That's right. That's
Yeah.
right. And
Hopefully
there are other indiscretions. I mean, the marijuana use is quite common. There are other shared activities which you certainly would not advise in a preconception mode, where the guy has to go along with the decision as well. And of course, passive smoking, for example, there's evidence that is negative to the female partner. So you can hardly have him have a pack a day and her have nothing, because she's going to get some. So.
And Stephen, what are the sort of challenges that rural practitioners face when discussing fertility? Is it a slightly different situation in terms of the things that you need to be working with?
I think it can be a little bit different in a smaller community, because everybody sort of could be looking at the newlyweds and, when's this all going to happen and that sort of thing. I can still recall a young woman coming in quite upset because nothing was happening, and her father had said, you'd better change your bull, because things weren't getting along.
That's fairly direct,
was
isn't
a
it?
fairly agricultural approach, and I knew exactly what he meant.
So
but,
she moved to Melbourne.
Oh, exactly, yeah, where there's a bigger choice of bulls, I suppose. But it is very hard, I guess, when the scrutiny's on a couple, and the pressure's there if they feel they're not producing when they're supposed to produce. But I think at the stage that our couple's at the moment, it hasn't even got to that point. There is the issue about access to specialist care, and I guess when we move to the point of needing to do investigations, and I can still recall many years ago Rob writing me a very polite letter which you said that maybe I should have gone for a more specialised sub-analysis laboratory, for example, rather than using the one round the corner. And I wasn't sure about that. I thought, counting was counting, but obviously the technique of the technicians is important. For me, I thought, look, just pass a sample. Sounds awful, but just produce a sample locally, and we'll see what shows up. But if you're going to do one, I suppose it's best done in a more specialised laboratory, which is hard to access if you are rural.
Or certainly the second one, if it looks like there's a problem on the first, most certainly.
So screening on the first one's okay in a rural?
Probably. You know, you've got, pragmatically speaking, if it's 300 kilometres to the nearest specialist lab, that's a hell of an ask.
Yeah.
Well,
even the issue of taking the sample to the local laboratory with your name on it. I mean, obviously, the laboratories are very confidential about things, but there's a sense of scrutiny and having to remember your brother's birthday because you've put his name on the label when they are checking the marks. It can be quite embarrassing.
And what about those other issues too? I guess the cultural considerations. We've got many different groups across Australia. We've got people from Aboriginal backgrounds, people living in remote rural areas. What sort of factors do we need to think about there?
Look, to be honest, I'm really not sure what the view in Indigenous communities is about subfertility, and I don't know. No, I haven't.
I guess it's something as practitioners we need to be mindful of, that
certainly
different groups will have different cultural
most
views.
certainly in the cities like Melbourne, you know, when you've got many different nationalities and cultural issues at play, one has to very much adapt the level and the terms you use, the use of visual diagrams in some circumstances can be offensive. There are things you don't mention, you know, donor insemination in some examples is verboten, so you wouldn't mention it because you know that this couple would not accept that. So you have to be very flexible and understanding of what the patient's hearing and how they'll take that message home with them.
So it's really about health literacy, isn't it? Tuning in to where somebody's at and what's really shared information and understood.
I always feel safest when the patient's talking, I must say. If I can actually get them to tell me what they know about infertility and what they know about conception and things like that, then you can respond. But if you go into transmission mode and you're telling them what you think, often you do miss the mark.
And these days, if this couple has moved on to thinking about fertility in a more proactive way, they educate themselves, in inverted commas, with the internet and with various articles they find in women's magazines and so on, and that sets their mind as to what's possible for them. And I come back to Kate's point about people see 45-year-old actresses having twins, and they think, well, you know, if they can do it, I can do it. Well, obviously they're donor oocytes most of the time, and yet it comes across in the public press as being easily fixed through a technological fix, which is not there. So people often have a lot to say based on what they think they already know, and sometimes you have to kind of re-educate them about what the things is really true.
Yeah, that's a gentle process, isn't it? You need to be very respectful about people's misunderstandings, but obviously steer them towards what we've got evidence for, and we're lucky there is good evidence.
I guess that segues nicely into perhaps our next case study, which is on that topic of a slightly older woman who's looking at starting a family. Kate, perhaps you could outline the next case study. Perhaps she's been reading some of those glossies and thinks that time is on her side.
Yes, and this is a very common scenario we deal with. And this is a 37-year-old woman called Jane, and she's overweight. Her body mass index is 36, so she's in the obese category. She's just started trying to conceive for a couple of months with Bill, her partner, who's 42. And she has been reading quite widely and quite intelligently, and she's really come to just have a chat. She actually hasn't brought Bill with her today, but she's just come to have a chat to find out about how she can optimise her fertility. So this patient's quite tuned into the fact that there might be some difficulties, and she really wants some advice now that she's just embarking. So she's really at the next step on from the first case that we had today. And she wants to know what's important. And I think that some things that are really important to talk to her about are going to be her age and the impact of her age on fertility. Women are stunned that at 37, their fertility is already somewhat impaired. The number of good eggs that they have is reduced at 37. That starts somewhere in the sort of early to mid-30s. And it's not a tangible thing. You have regular periods and you have pain with your periods and they're clockwork, and you get mid-cycle symptoms of ovulation. You have no concept that the eggs might not be as good as they used to be. So I would be talking to her about the fact that fertility is starting to decline at 37, and the time to get pregnant, or what we call the time to conception, is likely to be, several months longer than it would have been at 33, 34. and there is a slightly higher risk of having abnormalities associated with the wrong chromosomes in the eggs and a higher risk of miscarriage. You don't want to be overly pessimistic, and you don't want to sort of cause panic and make her think it's hopeless at all, but you just need a sort of a gentle chat about the fact that it could take a bit longer, and we need to be quite proactive about this. And I'm really glad that you've started now, and let's see what we can do to help you in a non-medicalised, somewhat casual way, ostensibly casual way, really maximise your fertility. You know, fertility at 40 is a real problem for a lot of women, and I don't think women realise that 90% of their eggs are not going to be very good at 40, whereas at 35, maybe, you know, 25% of their eggs aren't very good. And so I think it is really important to reinforce that fact. The next thing that I think would be important to discuss with this woman is her weight. And her BMI is 36, which makes her obese. And, you know, after all these years of running weight loss programs, the thing that I realise most is that women feel it's an insurmountable hurdle, that they're never going to be able to make enough of a change to make it worthwhile. This is, of course, the best time to garner motivation, because these women want to get pregnant, so you have that added motivation, as well as the long-term gains of, you know, the long-term benefits of reduction of risk of diabetes and heart disease. And, you know, I would be talking to her about her weight, which could be potentially having an effect on her ovulation and her cycles, particularly if she has a tendency or has polycystic ovarian syndrome. Even when you have regular cycles, the potential to conceive is somewhat reduced when you are in the obese category, and there are lots more pregnancy complications as well.
So it's really about encouraging some
right.
lifestyle changes.
Yeah, and
in
I
that
guess
window
encouraging,
of time.
but encouraging that you can have a relatively minor degree of weight loss that will really help your ovulation and help your fertility, to make sure that they realise it's sort of manageable and reachable, and not just say, look, I'll see you when you've lost 5 Ks, because that's not giving any help whatsoever. I think you need to help them to develop strategies in terms of lifestyle management with dietary advice, exercise advice.
And what are the thoughts on exercise? So is increasing your fitness going to be beneficial as well?
I think there's no doubt that exercise, quite independently of weight loss and nutritional change, does benefit not just your general health but your overall fertility. And it's a mixture of resistance and aerobic exercise. Look, we would recommend 30 to 40 minutes 3 to 4 times a week, but you don't want to scare someone off with that. So we sort of start gently and work up. And I think the most important thing is to make people feel that they can do it with your encouragement.
Now, she's been on the internet, she's consulted with Dr. Google, and she's read that maybe she could get a simple blood test that would give her an idea of how many eggs she had left.
Yes.
What are you going to say to her?
Yes, well, this is a very vexed issue. You know, there are a lot of women who think that they can come and get an egg timer test. It'll tell them how many eggs they've got left and how to plan their lives. And the test that these women are referring to is AMH, or anti-Müllerian hormone, which is a hormone that's produced by the small growing follicles in the ovary. And it's an indirect guide to long-term fertility. But it's not an overwhelmingly useful test on most of the occasions that it's organised. And I think maybe we shouldn't be blaming the test, but we should blame the incorrect and inaccurate interpretation of the test. Now, if someone has an incredibly low AMH, less than 1, then that is significant in a young woman or a woman up to her mid-30s. But most women in their early 40s are going to have very, very low AMH results. And a low AMH result doesn't mean you can't get pregnant. It just means that you probably won't be able to get pregnant in a few years' time. The low middle range of AMH is notoriously misinterpreted, and I find it really not useful. But a very, very low, significantly low AMH, i.e. less than 1, is important in a young woman, whereas in a woman who's 40, an AMH of less than 1 means nothing. But a lowish AMH, you know, the centile of 25 to 50, is really irrelevant and really shouldn't dictate further management.
And now they've been to the pharmacist, the local pharmacist, and they've said, what else could I be adding to the picture here? Is there any advice that we could be giving our patients about any additional supplements or any additional nutrients that may make a difference. What's the evidence there? Obviously there's folic acid with preventing neural tube defects. What about the bigger picture?
I don't think there's a lot of evidence behind natural therapies, are there? I mean, zinc was around for a while. I don't think that's been proved. But
there's a great many products that are proffered on the internet and in the pharmacies to boost, various, both your sexual performance and your fertility.
Yeah.
But to my knowledge, they really are not evidence-based. They're likely to be harmless, not harmful.
Yeah.
And so at worst, they're going to cost $1 a day.
We're in no position to criticise placebo effect, I suppose.
No.
We do it all the time.
And clearly, that is the issue, because to establish the particular fertility benefit of a treatment, you've got to have a group that's untreated, a placebo group, and demonstrate a difference between the prospects for the treated and untreated. And that's almost never done. Antioxidants are probably the best example of medications to which there's a great deal of promise and promotion with very thin evidential basis. There is some evidence that perhaps there's a benefit to antioxidants, but it's well short of grade A evidence. And so many of the patients that I find are already on antioxidants. I don't stop them, but I don't offer them myself.
But that could also get back to a healthy diet, couldn't it? Because you need to find
that's right.
a wonderful array of antioxidants just by eating a lot of colourful vegetables and fruit.
Well, antioxidants are used to sell everything now, and I'm not sure there's any evidence that they've ever been shown to have a benefit to any human condition. There's been much promise in heart disease and so on, and they've turned out to be essentially useless. So I would comment that people do take alternative therapies, and sometimes they import them overseas, and you don't know what's in them. I often get asked, I'm on, Wizzo juice from such and such, and is that okay? And I don't have any idea what's in it. When the study was done in the US, some of those chemicals actually do have biological effects, which are arguably harmful. So I don't like people taking things they've got off the internet, because I can't vouch safe for what's in them. I'll make one other quick comment, because I make sure if I forget to do it later on. Testosterone, or male hormone, it will never boost a sperm count. It is, in fact, suppresses sperm production. It's a contraceptive. In the same way as the pill suppresses ovulation, testosterone will suppress sperm production. And every now and again, I have a well-meaning doctor who's tried to boost his patient's sperm count by giving them testosterone injections. By the time they see me, they've got a 0 sperm count, and I have to take several months to back out of it again. It's reversible. Very embarrassing. So, of course, people who go to the gym and perhaps taking steroids at the gym, there are people like that. They will also always have a very poor or 0 sperm count. But I guess I'm saying you do have to, in a non-confrontational way, which picks up a point that Steve made earlier on, explore what people are actually taking. What are you taking exactly? And I can remember very well one guy came in, and I looked up on the web when he was there, and it had androstenedione and DHEA in it. I was saying, man, no, do not take that.
So DHEA will cause the same problem?
Well, this was a whole mixture of weak androgens. It's just not a good idea. It has no benefit and could arguably be partially suppressive.
Sure.
So you have to explore what people are taking. That includes people who go to the gym. And, generally speaking, they will say, oh, yeah, no, I do on occasion have a shot. It turns out they're on bucket loads of steroids. But you have to bring these out in discussion.
Yeah. So really it's about getting back to our original point, which is developing rapport and trust, and really understanding from the patient's point of view what their knowledge is and what they're actually doing themselves, and pushing those sort of key lifestyle messages the whole time about the things that can make a difference. But on this point of men, perhaps that could bring us into your case study, if that's all right, Rob. From the male perspective, perhaps you could describe your case for us.
My gentleman's 41. He's come along basically because his wife was concerned about the fertility, and the local doctor arranged a sperm count, and it's come back at 1 million per mil, very low sperm count. And he's completely twitched out about this. He comes along and really he says, I smoke a bit, I drink a bit. Could that be the cause of it? Is that why I'm infertile? Can I reverse this? The difficulty about male infertility is that, on the whole, it is likely to be a sperm production problem which is inborn to the man. It's a genetic problem, and those ultimately aren't able to be treated directly. But this comes to the key point, which has been made several times. The guy has to be evaluated thoroughly, with a thorough medical history and a physical examination. And in that medical history, You're focusing on previous fertility attempts, normal sexual development, sexual function, evidence of testosterone sufficiency or deficiency, history of trauma to the genitals, undescended testicle surgery as a little child, or inguinal hernia surgery as a small child. These are very important pointers towards possible sperm production problems. So this gentleman, my 41-year-old guy, it turns out that he actually had an undescended testis when he was little, and that's already getting my mind towards thinking this guy's got a sperm production problem, which is inborn, and whilst it's clearly a bad thing to be smoking and drinking too much, and I'll encourage them not to do that, one really couldn't point the finger at those and say this is likely to be your problem. The thing is, when you're evaluating a patient with infertility, you've got obligations, and the first obligation is to try and make a diagnosis, give an explanation for what's going on. With any luck, it'll be reversible. With good fortune, you can restore natural fertility and get your sperm count up. Even if you can't fix it, you owe it to him to tell him that the problem is there, I can't fix it, and then discuss options. And there are all range of IVF options and so on that are available. And the other thing to emphasise is that fertility problems in men is associated with a high risk of certain conditions, such as testicular cancer and testosterone deficiency. So it could well be, although he came along to see you worried about a low sperm count, you will pick up during your investigation that he's got some problem with his testosterone production or with his sexual function or testicular cancer. So there are multiple reasons why the guy needs to be thoroughly evaluated.
Because we so often thoroughly evaluate women, don't we? And we have that opportunity when they come in every second year for their pap test to have the conversation, have a physical checkup. Whereas men often just slip through the net, don't they?
They do not get routine genital examinations in adulthood. And we know this, I think, by one classic condition, which is the archetypal condition of male reproductive health, Klinefelter syndrome, 47XXY chromosome. This is 1 in every 600 men in the population. And we know from epidemiological studies that only about 30% are diagnosed for their entire life. So 7 out of 10 Klinefelter's men are never diagnosed. They die unrecognised, usually at a fairly normal lifespan, but nonetheless, they've missed out on the opportunities for treatments with hormones and so on throughout their life. Why is that? Well, it's likely to be that some of these guys are not particularly health literate. They perhaps don't go seeking to be examined or whatever. There's also that there's not a culture of routine genital examination in general practice very often. Because if you examine these guys for 1 second, his testes are unequivocally small. They are the size of the end of your finger, like a small sultana grape. You couldn't miss it if you examined it. And I make the diagnosis for this 41 or the 35-year-old guy because I'm the first person to ever examine their testes since puberty. So I think it tells us something about the level of comfort we have for genital examination. So Andrology Australia is one of the major points we make for general practitioners is to normalise reproductive health evaluation, both in the infertility context, but also in the general medical health review context. It's okay to examine the genitals.
Because this might be the first time they actually come for a consultation, because all the men's health focus tends to be on prostate and, 40s onward.
Yeah, heart disease, diabetes prevention.
Coming along with their partner might be really the only time, or for your opportunity.
Well, they may have insurance exams. There are other reasons to examine men in
the
the
pap
younger
test
life.
is sort of the ticket of entry to the female genital examination. There's not really something in young men.
There used to be.
Do.
In fact, Dr. Klinefelter made the diagnosis on military recruits in the Second World War. They all got examined. And he said, gee, there are all these guys with these very small... And that's how Klinefelter syndrome was discussed, because there was routine examination during military exams.
Yeah, the small arms inspection, they called it.
Small arms inspection, right. But I think it's entirely reasonable to at least do one routine examination of young men. It's not a big deal. It only takes a second.
Yeah.
But I was surprised in doing the reading before the broadcast, just how common factors are, environmental factors and health factors for men's fertility is. I mean, as a GP, I didn't realise about ageing for men particularly. I mean, I think we do know pretty well about women, but it was quite astonishing to read that decline in fertility.
There is a measurable, if you like, modest effect of age on male fertility. After the age of 40 or 50, you can see declines in natural fertility, which is partly due to less intercourse as you get older, but also due to a modest decline in sperm quality. And in IVF programs, if you control for female age and just look at the male age, you can see an effect of male age. But to be fair, it's pretty modest compared to the female. I have a slide which shows a gentle slope like this and a cliff. And I think that's the sort of message. I think you can oversell the effect of age on male fertility. It's certainly there. But relative to the issue of supporting women to make the reproductive choice at a time when success is more likely, as Kate was alluding, that I think is the most important age factor for men, is to support their partner as much as to worry about their own age. We obviously know that many men in their 40s, 50s and 60s and beyond have children.
Particularly with young wives.
Particularly with young wives.
That's the stereotype.
That's right.
Wife. And there are actually, there's plenty of evidence for us, a measurable increase in birth defects and certain medical conditions in the offspring of older men, which point to the fact that there may be more subtle mutations in sperm of older men. But these are very unlikely events. But it does show you that age does affect the male. My point is it's not as profound and precipitous as it is for the female.
What about the impacts of stress on fertility? Is there any evidence there that stress has an impact?
Well, in the male, stress would be manifest by a reluctance or an inability or a less frequent ejaculatory intercourse. That would be the most likely. Depression and so on is associated with sexual dysfunction, erectile dysfunction. So sure, if you're saying does stress directly lower sperm production in the testis, that's pretty hard to evaluate in the human. Animal models you can demonstrate it. So I guess it's possible.
But it's one of those very grey areas. I guess that patients will sometimes come in and they'll say, we've been trying and trying and trying, and we went on a holiday and hey presto. And in their mind it's been cemented with a less stressful environment.
Sure, but what about the female? I mean, is ovulation affected by stress?
That's a good question. I mean, there are the obvious things like extremes of weight and, change in eating habits and exercise associated with stress. Both ways will affect ovulation. There's no doubt about that. But the more subtle markers, a lot of women come and say, my job's so busy and we're trying to get pregnant and I'm so stressed. Should I give up my job because that's making me so stressed? And there are lots of studies on stress, but good research on stress is very difficult to achieve because the endpoints are very, intangible. And I mean, I guess you would say that significant stress can have a very subtle effect on your fertility. But really, I say to people, there's no problem being busy. It's when you're worrying about how busy you are and how stressed you are that has the biggest impact. And aside from the impacts of your weight, and I think that's where the natural therapies come in. A lot of women feel better by doing acupuncture and having herbs, either Chinese medicine herbs or naturopathic herbs. And I guess they feel better in themselves.
The same with the guys taking antioxidant therapy. I mean, one likes to be in control of one's destiny, and even if it's harmless and empirical, you're likely to do it. And I do not judge, but I would do probably the same thing myself. So, but it's a difference between accepting it as an expression of the human's desire to be in control and do something, as opposed to proffering it as a direct treatment.
Yes.
If I can just come back to my case for 1 second, because another thing that one sees is advice being given to my 41-year-old guy with a sperm count of 1 million. And they've been trying for 12 months and they're not pregnant yet, and he thinks that they're never going to get pregnant. There is a background chance of pregnancy, even in men with very low sperm counts. For example, this is the work of Gordon Baker, a very renowned colleague of Kate and I. Many years ago, he followed couples where the sperm count was at various levels, perhaps between 1 and 5 million. And from the time they started trying to get pregnant until conception didn't occur, about 30% of those men with counts of 1, 2, 3 million, which is pretty low, got their partners pregnant within 2 or 3 years. And so what you see is that those fortunate ones who are going to get pregnant despite the low count will do so in the first 18 months or 2 years. Then their chances really flatten off. And so when you're consulting with people about, what should they be thinking about doing next, clearly the degree of sperm impairment, the duration and conscientiousness with which they've been having sex and for how long is the next factor. And obviously the age and reproductive health of the partner, because the outlook's entirely different. If you've got this guy here who's been trying for a year, but his partner is 39, has got a blocked tube and has polycystic ovary syndrome, you can imagine how the two things add together. So the advice that you give about the natural prospects are very much informed by his level of a defect, her level of issue, and the conscientiousness and duration they've been trying. And these are the equations that we in the fertility area are always putting together on a personalised basis, trying to give advice to the patient about what's the next thing they can be considering. Would you?
Absolutely agree. Absolutely.
Yeah, so it's something with little steps along the way, and every case is truly individual, isn't it?
Very
in terms of the
individual.
factors that are involved.
Yes.
And I guess our role in general practice is often to work through those factors.
In the rural setting particularly, I guess, where people are going backwards and forwards from the big city, where inevitably the fertility specialists tend to be. And I guess it's important for the GP or the primary care clinic to have information about what messages to continue promoting and what to continue to do between the visits, because it is difficult getting to the city.
Yeah, and that's where resources come in handy as well, isn't it? Resources like Your Fertility, where you can go online with a patient. I had somebody in the other day, and we were talking through the age conundrum, and we just went on the internet together and pulled it up and watched the clip and explored that, and it was a great talking point. And I could have been here, or I could have been in Darwin, I could have been anywhere.
I think that's particularly important, Caroline, with things like caffeine and alcohol, the sort of consistent general messages between the primary care physician, the specialist, the community, every magazine you read. So resources like that give consistent and practical information are really good.
Yeah, well, alcohol's such a difficult one, isn't it? Because there's so many mixed messages.
Yes.
They're getting pregnant on holidays, probably more the pina colada effect, I guess, than anything else. But too much is too much. It's about moderation, I suppose.
And I guess that we're dealing with a community who's largely resistant to alcohol messages, aren't they? You know, safe levels of alcohol consumption across the board. That's a challenging area for us.
There's no safe level when you're trying to get pregnant.
No,
is the
and
thing.
so
And that's quite a challenge.
And so, how do we bring that up with patients, and what do we advise them there?
I would personally tie it into a whole lot of messages and just try to point out that if they really want something to happen, it's about expectancy. Literally, in this case, it's about, you know, if you expect this outcome, what can you influence that can actually give you the best chance of achieving that outcome? And if, you know, sure, alcohol is pleasurable, however, the connection between alcohol and lowered fertility is quite clear, as is with smoking and weight and the other things. So really, if you want to achieve that outcome, you're going to have to do some work. And you know, I'm here to help you do that as part of the team. But it does require you to make some effort in order to achieve the outcome that you both want.
So it's capitalising on that motivation, isn't it?
Yeah.
And perhaps working out what's in it for them and what they feel they can actually
yeah, I mean, why would you do
target
anything
first.
if there's nothing in it for you? That's what it's about, isn't it? If you really want this outcome, we'll help you work towards it.
But I guess that those lifestyle interventions will have far-reaching effects, because we're not just talking about fertility, we're perhaps talking about setting up a blueprint for a healthier future across the board. So
Well,
you'll be
healthier
healthier parents and
you're creating a family here, so
Yeah,
let's
a
think
healthy
about the
family.
whole family health and
Yeah.
what sort of lifestyle you're going to lead as parents and what sort of diet messages you're going to give your children and smoking and things like that. So the evidence or the reasons start to mount up for people to actually change their behaviour, and getting pregnant's the first step, but there's a whole lot of stuff downstream that I think just then should snowball from there.
So on that area of lifestyle intervention, Stephen, what do you think is the take-home message from today, from your point of view?
Getting pregnant is one of the major effects or events in anybody's life, I suppose, and for a couple it's often what they've come together to achieve as part of their relationship, and in some ways it gives you the ultimate justification for lifestyle change and sustained lifestyle change. Unfortunately, being a parent is stressful, and if anything is probably going to make you look for some of those comforts in life, maybe it's the struggle of being a parent. But that's where a longitudinal relationship with a primary care service is so important, to anticipate people running into problems with the terrible twos and when the next child comes along, school and things like that. And it's continuing to give those positive messages all the way through the person's life so that they lead a healthy life and that the next generation of children then grow up with those healthy lifestyle messages as well.
And the primary care team can really be involved with that as well. So we're not just talking about the GP, we're talking about the practice nurse, healthcare workers.
It's the whole community really is the thing. I mean, a healthy community is really what this is all about. And bringing children into a community that's going to be healthy and support them. Sporting teams and clubs and things like that, keep them busy.
And Kate, from your point of view, it's targeting lifestyle changes in a sustainable way. That's the message that I've heard again and again today. Can you?
Yeah, absolutely. I
that?
think, as Stephen says, what we're doing is harnessing an opportunity with a short-term goal, which will make changes that will really affect the long term. And to me, the important thing is for patients to realise this is not just empty rhetoric that your doctor's filling out because they've had their education seminar. This is really important stuff that actually makes a big difference to not just your fertility, but your reproductive health and the long term. But you need to be able to do it in a sustainable way.
And we need to have confidence as practitioners to be able
Yes,
to bring it up
absolutely.
and gently explore some of these areas as being a health issue.
Without driving our patients away, as Stephen was saying, without them going, oh, I'm not going back to that person on their soapbox.
It's a fine balance. Yeah, it's part of the skill.
But encouraging those little changes and, as you say, small steps, having realistic goals.
Yeah, absolutely.
So that you can enjoy the momentum, creating some momentum. Okay, good. And Rob, from your perspective on the lifestyle front?
Well, I obviously agree with the comments made, and I guess that it's important to remember that the guy contributes not only individually but by support of his partner to all of those outcomes, and that for his reproductive health and his long-term health and the ability to be a good and long-lived father, looking after your exercise, weight, smoking, drug use, other related behaviours is important. It's important to support the guy, that he's not sort of left out of these discussions. It's not just the lady going to the fertility specialist, it's us going. So, and it's great to see the couples addressing this problem, you know, shoulder to shoulder, rather than one person taking all the weight and the worry. So I try and get the guys to understand what their partner's going to go through and what might be involved for her, and how he can help her to that goal. So, yeah, I think it's a team effort. As I say, you can't be infertile by yourself. So you need to be a team.
But I guess, as you say, encouraging the couple to come along together to be there in the consultation, because very often women go through many consultations alone, and then they have to go home and relay what they've been told, and sometimes that message can be changed in the translation, and it's difficult to sometimes include
By the time
everyone.
they come to see me, they're already pretty open to what needs to be done and discuss. And most couples, I find, are very cohesive in listening and asking questions. And I can imagine them going home in the car afterwards, and then they ring back with questions they forgot to ask. And so you really can't give them too much time or too much feedback on their concerns, because they may not be all asked in the first consultation. You do get phone calls at funny times and people coming back because they had something else they thought might have been important that they forgot. So, and of course the local doctor's in an ideal position to give that continual reflective support whilst getting, hopefully good service from people like Kate and myself.
And this is an opportunity for a plug for your website. Where can men get more information, or couples get more information on men's health?
Andrologyaustralia.org is a very open portal, andrologyaustralia.org, and we will supply their downloads and the booklets, and everything, of course, is at no charge. That covers a whole range of male reproductive health, including prostates, erectile function, testosterone, as well as fertility issues.
Would either of you like to add anything else at this stage?
No, I think this is just a great example of prevention.
I think there'll be a lot of surprises. I think there are a lot of myths and misconceptions. We've covered them today, things like timing, things like the impact of age that we don't have forever, and even things like weight. I think that a lot of people understand the connection between weight, diabetes and heart disease, but people may be quite surprised that weight can also impact on our fertility, and the good news there is that even small amounts of weight loss can actually start to turn that picture around. So that's the encouraging news for patients and for their practitioners.
Such a switch around for a couple too, isn't it? To go from spending the first part of the relationship desperately trying not to get pregnant to suddenly switch it around to trying to get pregnant. It's a change in mindset.
Yeah, that's right. So thank you very much for being part of our panel today. And I hope that you've enjoyed this program on optimising patient fertility and the importance of lifestyle factors, those factors like age and weight, alcohol, smoking, cessation, and, as we've heard, the timing. So if you'd like any more information on any of this, we've mentioned the Andrology Australia website and also the website at yourfertility.org.au. So thanks to Fertility Coalition for making this program possible, and thanks also to you, our audience, for attending. If you're interested in obtaining any more information on the program, if you'd like to watch it again on the website, if you'd like to obtain a free DVD, please contact us at fertility.org.au, yourfertility.org.au. And don't forget to complete and send in your evaluation forms to register for CPD points. Thank you once again for joining us. I am Caroline West. Thank you very much to our panel. Goodbye for now.